Hello again to yet another educational video from Champion Health System. In this video today, we will know everything about osteoarthritis as demonstrated and described by our very own Dr. Radhakrishnan Ramaraj, MD, FS Chi in Interventional Cardiology and Endovascular Treatment. If you are suffering from osteoarthritis and you're looking for a solution of complete treatment, then this video is for you. In the next part of the video, you will see Dr. Raj demonstrating everything you wanted to know about osteoarthritis and his treatment. Now let's get to the video.
Good afternoon, everyone. I'm just going to record this session so you guys can look at this and see what we are doing. So the main topic today, we are going to be talking about musculoskeletal embolization, and this is a new paradigm for pain relief. And I have been doing this for the past 6 months and I have incredible result. And you know, osteoarthritis affects about 30 million adults. Almost 10% of people are affected over the age of 45, and it gets more and more as we get older. And there are many etiologies for osteoarthritis: mechanical stress, inflammation, obesity, aging, genetics. The main culprit that we are going to be talking today is inflammation, and how we are going to be stopping these patients' inflammation and helping them to be pain-free. The main problem with osteoarthritis is it is not the pain, it is the medicines that they take. The non-steroidal anti-inflammatory such as ibuprofen or diclofenac, these causes about 16,000 deaths in a year because of GI bleed, renal dysfunction, and also patients are getting addicted to opiates because of pain. And osteoarthritis starts at a very young age, mostly in men who are involved in sports, and as they age, you can see that there's equal incidence in men and women. And I'm not sure whether you can see my arrow here. I can use a laser pointer. So in a normal individual who does not have osteoarthritis, they have a normal knee. When they have inflammation, they can have genu valgum or genu varum. So the joint is destroyed. There is a space between femur and tibia. That is, you can see this is a normal space. In patients who have osteoarthritis, the joint space narrows, and this is called bone on bone. And when a patient suffers from joint pain, initially they do not take any treatment, or they may try ice, elevation, or some creams. Then they transition to medical management. They start taking NSAIDs and maybe some Tylenol for pain. And when the pain gets severe, they start getting the joint injections. There are multiple types of joint injections. They can have corticosteroid, which gives them very short-term relief. Some patients also get gel injections, but nothing gives long-term relief. The gold standard currently for pain, which is not relieved by any of these other three modalities, is knee replacement. Even with the knee replacement, not everyone gets pain relief. So we are going to be talking about a treatment where it is between joint injections and knee replacement, but also it helps to postpone knee replacement and have a long-term results. As I told you, historically, everyone thought it was a wear and tear, but the new evidence shows that it is not the wear and tear is causing joint pain. It is the low inflammatory disease which affects the synovium. So the synovium is the capsule of the joint. So when you have inflammation, particles such as chemokines, cytokines, metalloproteinase, what they do is they cause damage to the synovium by doing angiogenesis. They increase the blood flow, which are actually abnormal vessels. And once there are abnormal vessels, they recruit more inflammation and they can start damaging the cartilage. Once they start destroying the cartilage, even the bones get destroyed. The pain mainly from unmyelinated sensory nerves, which is nothing but, if you think about an electric wire with no insulation, it gives you a shock. Similarly, these patients have chronic pain just because of these sensory nerves which are being fed by this new arteries supplying the synovium and capsule. This is a guideline directly from American Association of Orthopedic Surgeons, and this guideline is from 2022. They have actually downgraded multiple treatments, including manual therapy, massage, laser treatment, acupuncture, nerve stimulation, electromagnetic pulse wave therapy, extracorporeal shock wave therapy. All these different types of treatment have been shown as it does not work or it has no benefit. The patient's symptoms of osteoarthritis is mainly because of synovitis. So it is actually a cycle. So in the cycle, if you can break one of the components, you can actually stop the pain. When patients have osteoarthritis, they have angiogenesis. Angiogenesis is nothing but formation of new arteries. And these recruit vascular endothelial growth factor, which is nothing but it increases the blood flow and puts new arteries. Then it recruits metalloproteinase, chemokines, and this is a cycle. So as a vascular specialist, what we do is we actually stop this angiogenesis, and therefore we cut down the pain and the cycle. We use a score called UMAC score. UMAC score says how much is the patient suffering. Higher the score, worse the symptoms are. And we also use a score which is commonly used is visual analog score scale. You can use either this score or UMAC score, and higher the score, worse the pain. As usual, everyone wants to have a data whether this procedure works or not. And we know that initially these studies have been done in Japan. It was started in 2017 by Dr. Okuno, and he was the one who actually invented this procedure that he found in patients with inflammation and patients who have tumor. There are new arteries supplying that area of tumor or inflammation. When he injected emipinum, it's an antibiotic, with contrast or saline, it formed small particles, and these particles only affects the inflamed arteries, not the normal arteries. So he did a single arm trial, and the success rate was about 80%, and patients had a 50% decrease in UMAC score. And I have, you guys may know, I recently went to Japan and I got proctored by Dr. Okuno himself, and I did about 30 cases with him. And there are other studies which have been done by Bagla, Landers, and these are all single arm trials. And almost everywhere there is a good decrease in pain score. And the latest one which is going on is by Landers. These are all randomized controlled trials. And we are also going to be involved in a new trial in the US. Champion Health System will be involved, and I am the primary investigator. The name of the trial is called RESORB, RESORB, and this is a trial which is going to be starting in the US. We are waiting for the final paperwork, so we will start trial on the GAE. So current studies have shown that once GAE is done, the VAA score decreases about 50%, and it sustains for 12 months. There are not many like injections or gel procedures can say that the pain is reduced and they can sustain the pain relief for 12 months or more. And Same thing with the WOMAC score, it reduces and the pain is sustained, pain relief is sustained for more than 12 months. This is an example. This is a knee MRI. You can see there's a white spot on the side of the knee joint, and that is the synovitis. And this is what the vascular, so we do an angiogram and find exactly which branch is supplying the pain. And we find that area and we inject microsphere, either antibiotic microsphere by emipinum or other commercially available microspheres. So what I use in my practice is emipinum, elasticin, and the combination is called Primaxin. So this is what we use in our patients, which is what Dr. Okuno used, and he has done more than 5,000 patients with no side effects. So what happens with emipinum? Emipinum becomes a crystalline structure and dissolves within 4 hours. So it's gone out of the body in 4 hours. And it actually, by doing that, it reduces the inflammation related to microvessels and decreases the inflammation because of the mononuclear cell infiltration. This is an example what we do. We go and take a picture of the painful joint, either a knee joint, shoulder joint, and find an area where there is a blush, BLUSH. So you can see an extra vessels here. Then we inject microparticles into the area. And once we inject the microparticles, the blush disappears. As I told you, emipinum only affects the inflamed arteries, not the normal arteries. So there is no damage to blood flow to the muscles or blood flow to the bones. And in the normal arteries, it gets flushed away, but in inflamed arteries, it stays for a longer time. So this is the results of osteoarthritis treatment. And you can see the visual analog score. Initially it was about 59 patients was studied, and initial pain score was 8. Within a year, the pain score went to 1.8. And people who were using non-steroidal anti-inflammatory, there were 46 patients who were using it. At the end of 12 months, only 9 patients used it. Similarly, physical therapy and a gel injection, everything has gone down to from 39 to 2, and physical therapy 39 to 2. Even with patients who had a severe osteoarthritis, there's a dramatic decrease in pain. So this is one of the, so we use a microcatheter to go into the artery and find the area that is a blush. So, and most patients, when we inject the microparticles, they feel that area of pain, and most of the patients have pain relief on the table. And this is how the procedure is done. What we do is we initially get an IV either in the groin or in the foot. Most of the IV currently, what we do is we get it in the foot, so we don't have to use the groin. Once we get the IV, what we do is we put a small catheter into the IV, and this IV is much smaller than the regular IV. We put it in the wrist, and patients can leave the office within half an hour after the procedure. So you see the catheter goes down the artery, and we find the artery which is supplying the inflammation. And once you see that red color artery, so we put the catheter down to the vessel which has inflammation, and then once we find that artery, we inject microspheres, and microspheres goes into the inflamed vessel. It only affects the inflamed vessel and does not affect the normal artery. We inject, there are about 6 arteries which are supplying the knee joint. There are about 6 arteries supplying the shoulder joint. The hip has 8. So we try to find which artery is causing pain. We usually mark the skin initially before the patient is put on the table, so we know exactly where the pain is. And if the patient has pain patient has inflammation. And after injecting, most patients walk away after the procedure and they have no pain. So what are the different types of pain we can help? Tennis elbow, jumper's knee, Achilles tendonitis, wrist joint injuries. We could do Heberden's nodes, or any pain in the pisiform bone, hip joint pain, lumbar pain, spondylitis, sciatica, neck pain, any fractures in the past, it's not getting better, shoulder pain. We can also help with the gout. So I am involved in the new trial using NextSpear. So this is a new embolization particle made of gelatin. Actually, this also disappears from the body within 2 to 3 hours. So it actually works just like emipinum, but with less side effects because it's an antibiotic. This is not an antibiotic. It's a natural substance which actually gets dissolved in the body heat. So here you can see what kind of artery supplies the pain for each of the pain condition. And nowadays more people are playing pickleball and they have elbow pain. This can be helped because there are micro tears in the tendon because of repetitive injury. This can be helped with this microembolization technique. We say it's a transarterial embolization. And this is the area of pain. So we can go through the radial artery and find the exact spot of pain and inject the microparticles. And this is the elbow joint, and you can see the inflammation, and you can see the blush in the elbow. After we inject the microparticles, the pain is gone. In shoulders, same thing. We have many areas of pain. We can target exactly like frozen shoulder, rotator cuff injury. And similarly, this is another shoulder, frozen shoulder. And what happens after transarterial embolization? So we do the embolization. So when it started, we inject the microparticles. This is a MRI picture. You could see after 6 months, all inflammation is gone, and many patients can avoid surgery once we do these procedures, because we have even seen patients who had a bone on bone, the synovial fluid gets reaccumulated and they feel there is no more bone on bone. But we cannot do anything more for patients who had marrow destruction. These are the patients with Achilles tendonitis. So patients who have pain in the Achilles tendon, you can see the white color inflammation in MRI, and we find the blush and we inject the microparticles, the pain is relieved. This is the patient with a gout. So we go to the foot and find the area where the patient has significant pain from the gout, and these patients can be helped for the gout pain. And this is a patient who had an ankle sprain, and patient was not getting better even after surgery. So the patient came in after 20 days of surgery and still in pain. So we were able to find, what was the problem and was able to fix it. So you see the whole foot with so much of inflammation. And similarly, patient with the pain in the osteoarthritis, they can have, Heberden's nodes. You could see there are inflamed arteries in the tip of the fingers. So we could also treat finger pain, wrist pain on phones, and they like to keep texting and have a lot of pain in the wrist, a lot of pain in the thumb joint can also be taken care of. So this is how we do it. So we, in patients with pain in the thumb, what we do is we inject emipinum. When we inject the emipinum, you could see it actually affects all the micro vessels, and within few minutes, it treats the hand, and the patient is pain free. So that is what. So there are some. The safety complications are very, very minimal, like skin discoloration. Some patients can have rash and transient plantar numbness, and if we go through the groin, they can have a groin hematoma. But most of the patients, we go through the foot or through the wrist, so they have minimal time off, and patients can walk away from the office within half an hour. And who can benefit? Anyone younger the better, because we do not want them to go through surgery. anyone who have failed physical therapy medications and who are not ready or can't have surgery, any younger or active patients, active people who want to delay surgery, this is very, very good. And as I said, this is a very simple non-surgical procedure, recovery shorter than surgery. There is less chance of same day and most insurance plans covers it. And this is where I was trained. I was trained by Dr. Okuno, and he was the inventor of this procedure. And these are all his colleagues. And this is Dr. Okuno. This is the picture from Okuno Clinic. So currently, I'm the principal investigator of RESORB trial, and we use a NextSphere EF. It's a fast resolvable microsphere, and this is a multi-center randomized open label study. This is mainly for knee osteoarthritis. So we'll be recruiting patients soon. And if you guys have any questions, you can always talk to me. Thank you.
Dr. Raj, I have a quick question.
Yes.
So a couple of them actually. They noted if the cartilage continues to generate post-procedure, or it has no impact on the wear and tear of the cartilage?
So the current studies have not been focused on cartilage regeneration, but we have been only focused on pain condition. But anecdote with Dr. Okuno, he has found MRI studies that if bone marrow is not damaged, it is only the damage to the cartilage, it actually regenerates. But we do not have any studies to prove it yet. So they are conducting multiple studies. These are all MRI studies to identify if there is regeneration of cartilage.
So what level of care is required to get them to this procedure? Injections, bracing, course of anti-inflammatories. What would we have to do for a patient to qualify?
So for now, the only qualification is pain, and they don't even have to have knee injections in the past. If they have tried physiotherapy or NSAIDs and still in pain, they can qualify.
That's for the study or for just general treatment?
Even for general treatment.
Great.
But they have to be in pain.
Thank you.
Yeah.
So when you're doing the knees, is it much like the same concept with the shoulders? If there's multiple areas, inflammation and pain, you can treat all of those areas. Like in the shoulder, how the picture showed the multiple areas of inflammation.
Correct. So, yes, what we do is we go through all the arteries and find which artery is having the blush, and all those arteries.
Thank you, Dr. Raj.
Okay.
Very interesting lecture. Appreciate it.
Okay, much appreciated. Yeah, thank you.